This episode is brought to you by podiatrygrowth.com/Pod Patrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000, $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/Pod Patrol.
Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Dr. Marque Allen. Thank you for joining me tonight.
Thank you, Jeff. My pleasure. Thanks for having me.
Absolutely. So for anyone who doesn't know who you are, why don't you spend a minute or two kind of introducing yourself, telling people where you practice and how you got to be where you are.
Sure. My name is Marque Allen. I practice in San Antonio, Texas. I'm one of the founding partners of a practice called Sports Medicine Associates of San Antonio. I originally went to school in New Jersey. I did my 4 years of residency in Pennsylvania at the Pennsylvania Presbyterian Hospital and Penn Medical System, and then did a fellowship in San Antonio. Never thought that I would stay in San Antonio, but a right opportunity came about, and here I am 20 plus years later. And we've ended up founding the group Sports Medicine Associates of San Antonio, which now approaches 20 docs. We've got a multidisciplinary group, primarily of orthopedic surgeons and also non-operative orthopedic surgeons in the way of primary care sports medicine docs that all did sports medicine fellowships. So it's nice. I get to practice during the day, and I get to put the other hat on and run a business at night. And we've been blessed to be able to treat a multitude of athletes from middle school, high school, college, all divisions. We've been fortunate to have been the team docs for the San Antonio Spurs for 20 plus years. Along with the NHL teams, the NFL teams that we take care of and work with, AFL. So we've had a lot of opportunity to treat those types of folks, along with the general population. But in a given day, probably about 40% of my patients are somewhat sports related that come in, ranging of all levels: high school, middle school, college, and then still professional. So here I am, 20 plus years in San Antonio, and practicing, still having a really good time and keep learning.
I think that's interesting because a lot of people that I talk to, they became interested in podiatry because they were an athlete and had a foot injury and ended up seeing somebody, or they themselves are interested in sports. I love sports. I follow all sports. If people are like, are you into the NFL or hockey or basketball? I'm like, yes, 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 and yes. I follow it all. And so I think that's a pretty neat opportunity for you guys to have started such a niche opportunity. From orthopedics makes sense, but then having podiatry involved in that also makes sense. So what was the genesis of the group? You just had a bunch of guys that were like, hey, you like sports? I like sports. Let's start doing a sports themed group.
Jeff, you kind of hit the nail on the head. What we were we were 4 unemployed docs. When I came out of fellowship, I got hired into an orthopedic group in San Antonio, which at the time was called Orthopedic Surgery Associates of San Antonio. And it's interesting how this occurred, because that group at the time had a physician by the name of Dr. Mark Allen, who had done his fellowship with Roger Mann in California. And he was working with the residents at UT Health Science Center, and he and I had never met until we were at the graduation dinner for the residents. And he and I just fortuitously happened to sit next to each other. I had never met him, and we just got to talking about all things, talking about bunions. He
Mm.
was expressing to me how he could not solve bunions and hammer toes, and he hates them. So we just started having conversations about it. And over the next 3 or 4 months, I hadn't planned on working. After 5 years of residency and fellowship, I had saved up some money, and I just had some plans to travel. So I wasn't even looking for a job. And after about 3 or 4 months, he and I started hanging out. Before you know it, we were kind of scrubbing cases together and assisting and doing things. And we started to develop a really good camaraderie and appreciation for each other's talent and skills and knowledge and sharing of information. So after about 3 or 4 months of that, he came to me and said, "Hey, would you be interested in joining our group?" Well, at the time, I'm like, yeah, this looks like a great opportunity. I never thought I was going to stay in Texas. I
Mhm.
really thought I would head somewhere to the southeast or maybe back to California or something. I wasn't sure where I was going to go, but I figured, let me do this for a few years, hang out, do some board collections and get some experience. And he and I will continue to work together. So I joined them. And about 2.5, 3 years in, he comes to me one day because I was an employee physician, and he comes to me and says, "Hey, listen, I've got some news. At the end of the year, we're going to close the practice." And I was
Mm.
like, "Closing the practice?" It was almost unfathomable to me because from the outside looking in, we're in this beautiful building. You see patients coming and going. Everybody's busy. I couldn't make sense of it.
Yeah.
So I said to him, I said, "So what does that mean for me?" He said, "Well, it means the same thing it means for me. We're both unemployed as of January 1st."
Hmm.
Well, that group at the time had about 13 docs in, and 8 of those docs at the time, 9 of them actually, went to another group that had already been established in San Antonio, so to find a home real quick. Well, that left 4 of us. And so of the 4, it was myself, it was David Schmidt, who is an orthopedic surgeon, Paul Sines and Tim Palomero, who are both primary care sports medicine docs. So we were sitting around one day and we didn't want to go to the other group. And well, personally, I don't think the other group wanted us.
Mhm.
So we said, well, why don't we come together and form a practice? So we sat down around a table and said, well, what do we like? And to your point, we all said, well, we really like sports medicine. And even to this day, it's very unusual for someone to put their name out as we're going to do sports medicine. It's usually orthopedics or this and sports medicine.
Sure.
And we decided on that day that we were just going to put our name outside and this is what we were going to do. And we were going to reinvent how sports medicine in the San Antonio area was practiced. And that meant from the grassroots level to all the in-kind work that we do, coverage of the sidelines, high school physicals. Give you an idea, even to this day, 23 years later, our practice does 11,000 pre-participation high school physicals for free.
Wow.
It costs $25 to do the physical, and
Mhm.
all that money goes back to the athletic program of the high school. But we've got it down now. And at
Yeah.
that time also, we thought to ourselves, well, what do we have? We didn't have anything but the 4 of us. But we said, well, we've got the Spurs. We've got the San Antonio Spurs because my 2 older docs, they were the team docs for the Spurs at the time. So we figured we had something good to start with. And
Mhm.
at the time, we then went ahead and subletted 1,800 square feet from a company that was called Health South. Some of the other docs might remember Health South. They were everywhere. Well, Health South went into bankruptcy.
Hmm.
So we were then going ahead and subletting space from a bankrupt company. And so as the other group closed, we went upstairs, we took the stuff from the other office because we were in the same building and
Mhm.
we reformed this thing. And then from day one, fortunately people came, but our practice was built on a few things. And one is you have to be available. So we're available 24/7. Our practice will see any new patient within 24 hours. And if it's an athlete, even on the same day, somebody will see that person. So we needed to be available.
Yeah.
Then we felt that you need to be affable. All of us like to get along and be good people, and then you have to have ability. And if you don't have the first 2, we don't really care if you have the third one. And so since we have grown, we've made sure that we've kept the culture intact. And so anyone that joins us, they understand there's a lot of time, a lot of energy you're not compensated for. Sports medicine may seem shiny and sexy, but there's a lot of uncompensated thing you're going to do. We cover somewhere around 400 events a month. through an outreach program because we employ about over 100 athletic trainers that go out to the area all through South Texas.
Sure.
And our phones are constantly ringing, but it goes back to that availability thing. And so as time went on, we ended up building a big facility at the time. So we built it in conjunction with the Spurs. And the San Antonio Spurs have always tended to be a little bit ahead of the curve. And in that 2000, 2003 period, my senior partner, David Schmidt, and Peter Holt decided that they needed to build the training facility and the healthcare facility adjacent to each other.
Hmm.
And so we were the first in the league to do that. So we built a 135,000 square foot building called the Texas Center for Athletes. And all the specialists we put in there were everything or anything that team could need, from imaging to cardiology to pulmonology to you name it. And
Wow.
that's still our main building today. But now we've gone and expanded to 8 different locations and approaching 21 doctors. But the core principles have stayed the same.
Yeah, that's an amazing story. That's really, really interesting to hear all that, how you kind of start foundationally and then build upon it. One thing that caught my ear was that you employed athletic trainers, because I think one of the things that's difficult when you're a new practice getting up and going is how do you get market share? How do you
Yeah.
fight against the competition, some of which are have been longstanding in the community? It
Yeah.
helped that you had the Spurs, but it caught my ear that you said that you employ the athletic trainers because they're going to be boots on the ground, seeing the athletes and then referring them back. Do you think that was the biggest growth mechanism for you to actually get athletes in the front door, or was it marketing, or what do you think allowed you to eventually become so popular that you grew?
It's relationships, right? It is relationships, availability, and service. But to your point, it's the athletic trainers. The athletic trainers are the hardest working individuals in any school system. They're there before anybody gets there, and they leave after everybody. Those individuals, they're the ones with the pulse of all the athletes and the athletic program. And the athletic trainers, the way we have to look at them is that they're on an island when an athlete gets injured, okay? And they need to get off that island, right? Because they're in the center of it. They're the one that is initially trying to make this diagnosis, set up a treatment regimen. But we've got mom over here, we've got dad, we've got the athlete, then we have the coach. Okay, when is the athlete going to play? What is wrong with them? When can we get them back? This is my starting quarterback. So they're on an island. So that's where we come in, because now, as soon as that occurs, they're texting. Dr. Allen, so and so went down today. He can't stand on his ankle. Bring him over right now. So I immediately, me or my other partners, were getting the trainer off the island.
Mhm.
So now all of a sudden they have a team of help. So it shifts also the responsibility over to us. The parents bring them over the same day. They walk in, they have an examination, they have an x-ray. If an MRI is needed, we do it right there in place. And by the time they leave, when they leave, they have what you and I were discussing earlier, is those 5 questions that I came up with. So we try to have those 5 questions answered for that athlete, whether or not it's middle school, high school, college, or pro, all answered on that first visit. And that came about from working with the Spurs. And that was really an eye opener for me in around 2005, 2004. Now, if you think back now, the Spurs were on top of the world. They
Mhm.
won the championship in 99, 03, 05. This is in the midst of it.
Mhm.
And what I learned really quickly within a year's time was that when you're working with these level of individuals, there's so many people involved, whether or not it's a coach, it's an agent, it's a general manager, it's the trainer, it's the agents' physicians around the country.
Mhm.
It becomes very clear you have to be able to answer these 5 questions very fast.
So let's
Because,
talk about those real quick, and
yeah,
I'm gonna pop that up, and you just
yes, please.
keep talking.
So it became very clear to me, Jeff, that no longer was I able to go around in these general diagnoses, ankle sprain, Achilles tendonitis, metatarsalgia, these generalized diagnoses. Because what I was finding was they weren't giving me the ability to answer the number one question. And that number one question for all those involved is the last one here. It's going to be on when. Well, that's question number one. But when we get to question number 4, we'll see it. What everyone wants to know: when can I play?
Yeah.
And you're trying to wrap your head around this. And in order to consistently be able to get this, when can I play target down, you have to be able to answer these other three questions. And it occurred to me one time, I'll never forget this. I was working with Tony Parker, and these are open for discussion because they were public, and it's fine.
Mhm.
And Tony had an ankle injury at the time, and I was sitting there seeing Tony at the training facility, and Popovich walked over to me, and he just kind of being Popovich, he goes, "Okay, what the hell's wrong with him?" And I say, "This, what's going on?" He goes, "That's great. So when's he going to be back to play?" Because what I've learned also is coaches understand injuries are part of the game, but what they like is predictability. Can I pencil him or her in tonight, or can I not? And if I can't, I have to pivot. But if I can, you're going to tell me it's on this date. So you're telling me it's 6 weeks from now. And it literally, he said to me, so you're telling me on this Friday night against Indiana, he's ready to go. Yes, sir. Okay. And he walks away. So what you find is that come that 6th week, that day, you better be right.
Yeah.
Because if you start getting that wrong consistently, you're going to lose faith and confidence in you, and they're going to start to pivot. And so,
question 1 says, what is the
yeah,
diagnosis? So what you're
yeah,
alluding to is you can't just say they have an ankle sprain. We need to
that's
know
right.
which ligaments are involved. How severe are they? Is it fully torn, partially torn? Is one of them partially torn, one of them fully torn? The specificity is what matters in order to dial in the accuracy when it comes to return to play.
That's exactly right. So, to your point, the vague diagnosis of ankle sprain is not going to be able to answer question number 2, 3, 4, or 5. And so we've got to get number 1 right, and then that moves us into number 2, because oftentimes when you have these injuries, and you are well aware of this, it's not necessarily always just the ligament. There may be some mild inflammation or of the tendon. You could have some medial impaction edema of the medial talus. You may have some deep deltoid injury. You could have some medial impaction of the medial malleolus. So you have to give each one of these their separate diagnoses, and then we're going to grade them based on the severity. And the worst injury is going to take precedent to determine your timeline to return to sport. And so
Sure.
number 2 is, what is the severity of each, right? Because that's
Yeah.
really important. And I talk about using classifications and severities, and we can debate all days on the shortcomings or the strengths of a classification or severity. But at some point, we have to be able to speak a common language. So when I'm speaking to whomever, whether that's Marty O'Malley or Bob Anderson or whomever, we have to speak a common language. And by doing that, that's what helps us have a commonality of what we're talking about. So we're talking about the same thing. We're not just saying there's an ankle sprain. If I'm saying, hey, he's got a grade 2 ATF injury, he's got no medial injury, his peroneal tendons are perfectly fine.
Mhm.
Now we're on the same page. But if I talk to him and I say we have a grade 3 ATF, grade 2 ATF, we got a grade 1 or 2 of the deep deltoid and some medial impaction edema. Well, now we got to, we got bone injury and ligament injury. So now we can separate those out and work on both of those. But understanding that diagnosis or diagnoses, because there can be more than one, especially with grade 3 injuries, it's very common to see more than one musculoskeletal structure injured. So then we put a grading system to each of them. And that brings us to question number 3, and that is, what's the optimal treatment for each of these injuries? It's evidence-based medicine, and what's optimal treatment? And by doing that, it's going to allow us to give the optimal treatment to it. And that's why I put on there, your options: surgery, no surgery. Is there immobilization, bracing, hyperbaric oxygen? We get it all. We get, magnets, crystals, hope, prayer. And you got what the uncle is saying. We had that with one of our
Yeah.
infamous players that, well, elsewhere. You get a lot of input. And
Yeah.
so you have to be aware of all these things and these treatments, and be able to implement them. But at the end of the day, you understand what the evidence is saying. And so you want to try to get this accurately answering questions 1 and 2. So number 3, which is what's the optimal treatment for those, that gives us a real good foundation. And so if we can accurately answer the questions 1, 2, and 3, now we can get to number 4, which is the most important.
Yeah.
The athletes, it's interesting. Yeah, I'm sure you see this. You're talking and I'm talking, and we're telling them everything, and all of our academics are coming out,
Yeah.
and the athlete's eyes are glossing over. And we sound like
Yep.
Charlie Brown's teacher to them after a while. Blah, blah, blah,
Yeah.
blah, blah, blah. And, dad's
Yeah.
catching some, mom's catching some. And at the end of the day, it's about, when can I play?
Yeah.
When can I play? And if we don't get the diagnosis correct, the severity correct, then we're not going to get to the correct treatment, and we're not going to be able to dictate our return to sport time. And that's what's most important. And we may not be able to get it down to the day, but we can certainly get a reasonable range. And this is very common in treating ankle sprains. Me, all of us, we treat ankle sprains all the time. But I would tell you probably 30 to 40% of all the ankle sprains I see were already seen by someone else.
Mm-hmm.
And they come in and their concern is, I was told I have an ankle sprain, but it's 4 weeks later and I'm still hurting. So what they're thinking is, I wasn't given the right diagnosis. Well, what they weren't given was the correct education about the severity of what they got.
Sure.
So I can often say, well, no, you do have an ankle sprain, but you have a grade 3 ankle sprain.
Mm-hmm.
These usually take X amount of time to get better. You're 4 weeks into a 12-week injury. And so if you give them the information, then that gives them the confidence in you. So the thing with athletes, I think athletes also sometimes get a bum rap of like, they're not going to listen to you. They're going to do whatever they want to do. And I think it's quite on the contrary. If you lay it out for them and you tell them specifically what's going to be happening week to week or every 2 weeks, or here's a milestone by week 4, week 6, week 10, week 12,
Mm-hmm.
they'll follow it. They will definitely follow it. And especially in the collegiate or the professional athletes, they've got people that are going to make sure they're getting followed so that they'll
Yeah.
carry out that for you. But
So what are your thoughts on when you try to give an accurate timeline? There's
Yes,
three scenarios that I'm thinking of. The first is just giving a time range, just because we can't actually predict how quickly certain people are going to heal. But if you give someone a time frame, let's say that you tell them they'll be back in a month and it takes 6 weeks, they are very unhappy. But on the flip side, if you tell them it takes 6 weeks and they're back in a month, they're ecstatic. They think they're a fast healer. They think they're great. Is there any like gamesmanship there where you kind of give them something a little bit longer so that they're not disappointed if they aren't back at 1 month and a day because you said it was going to be 1 month? Or you just try to give them a range and say, here's how long this usually takes?
I try to give them a range, but a narrow range.
Mm-hmm.
Right? Because my feeling is, if the clinical exam is good, and I'm also considering the other external factors, for instance, what sport are they playing? What position are they playing? What type of injury have they had? What's the demand on that injury?
Yeah.
Then with the x-ray, the MRI, the clinical exam, if I have the specific injury, I can find out the what's the word I'm looking for? The severity of the injury. So if it's a ligament grade 1, 2, or 3, if we have a fracture, you and I both know how long those will take to heal. So
Sure.
when we put those together and we put them all together, or we separate them and then put them together, we can usually narrow that down pretty darn good. And
Mm-hmm.
if there's a reason why they missed the mark, then we probably missed something in the very beginning. And I think that's the challenge, is in the very beginning, in that first 24 hours, being able to answer these questions so there are no surprises 6 weeks down the road,
Yeah.
right? So I think that's the key.
Sure.
So I think we can get them in there and within that 1 or 2 week range. But to say this is a 6 to 12 week injury, I think that's too much gamesmanship, right? So because
Yeah.
I think we have to be able to do a little bit better than that, and we all can. We all
Mhm.
can. And this was really important here. We've had some players that have some injuries, and this is what the team's interested in. This may be a player that is in a contract year or an option on their contract, or it could be, I've had this with universities. Do we renew this scholarship or not? Or do we redshirt this player for a year because of this? And sometimes some injuries, regardless of being able to answer questions 1 through 4 the best we can, provide the best treatment that we possibly can, there's always a price to pay. in some injuries, right? And to your point, let's say somebody has a medial osteochondral defect. We know what the chances are of that getting better with appropriate treatment, but there's also, 20% chance or 30% chance based on the size, location, that you could need revision. This
Mhm.
is interesting because every year before the NBA um, draft comes about, the Spurs, we would always get the top 100 players in the year. And now all that information is kept in one database. And so every player is in there. And any injury that they've ever had or disclosed, and any test, any surgery, any note, anything is all placed in there.
Hmm.
So we will get that. And then if it's a foot and ankle injury, then it's shuttled over to me. And okay, then I have to give it a medical grade. So I
Hmm.
have to then look at what was the injury, what was the treatment, what's the outcome, and do we project that this is going to be a limited injury that's going to require no loss of time? Does it have the potential to lose some time, or is it potentially going to shorten their NBA career? So I have to be able to give it a grade on that. And good story. This is really an interesting story. The one that got me the most, and this is all public information too, because it was reported, nationally that he had these injuries.
Mhm.
Player named Chris Levert, who was coming out of Michigan. And this is
Mhm.
probably, I don't know, 6, 7 years ago. Karis Levert was a point guard for Michigan and easily probably a top 5, top 10 pick. That year, the San Antonio Spurs were going to be drafting 27.
Mhm.
The challenge with Karis Levert was Levert had fractured his fifth metatarsal 3 times. He
Wow.
had so he had done it in his, I believe, freshman year. He had done it again in his junior year, and I think it might have been his senior year or junior that he was coming out. So he
Man.
fractured it once, it was fixed. Fractured again, it was fixed. Fractured it again in January of this draft year. So when he
Jeez.
comes to see us, he had just had it fixed by Marty O'Malley in New York. So
Yeah.
we're sitting around the table, and the Spurs are thinking there's a possibility this person could drop to 27 because of this history. And
Mhm.
we're having this back and forth discussion. The first thing I had to do was go back and look at all of his medical records and his x-rays and figure out, why is he re-breaking this, right?
Yeah.
And what the commonality was, especially in some of these fractures in the lower extremity, whether it's anterior tibial crest, medial stress fractures of the malleolus, navicular fractures, Jones fractures, and sesamoid fractures. What I've seen consistently is it's a rush to return the play too soon.
Sure.
And the bone, even if the CT scan shows that it's healed, it just hasn't cured yet as much as it
Sure.
should be.
Yeah.
And so for Chris, he came back too quickly. And so here he comes in hobbling in for his interview, and he had just had the surgery. So we're sitting around the table, and I remember R.C. Buford looking at me and saying, "So does he have a 27% chance that he'll play 2 years in the NBA?" And I thought that was a really odd question,
Yeah. Yeah.
right? I'm going back and forth trying to talk about all the science and the fixing, and I do think he can work. And I asked, I said, "RC, I don't understand that question." He goes, "Well, here's the key. The 27th pick in the NBA draft only has about a 26% chance of being in the NBA 2 years later. So
Wow.
can we get 2 years out of him?"
Yeah.
And sure enough, Karis Levert's still playing today. He went on to be drafted by Brooklyn, and he's since went on. And but this time, sort of like with Kevin Durant and the others, they took the time. They gave him 6, 8, 10 months to come back, and he has not refractured it from there. But it's really interesting, those conversations.
Absolutely. So let's spin that off because I think we're going to end up maybe talking about some Achilles injuries. What do you
Okay.
think is going on? I've had Bob Anderson on podcasts before and other sports medicine experts, and seems to be kind of an uptick in Achilles tendon injuries, at least in the high profile athletes, NFL and NBA players. Seems to be a little more prevalent than it used to be. What are your thoughts on the increasing prevalence or incidence of Achilles tendon ruptures? Do you have any theories of why that might be? And what are your thoughts on overall Achilles injuries in high level athletes and how long it takes for them to get back?
Yeah. My theory on why we have this uptick in Achilles tendon injuries would be like you and I talking about the flat earth theory, truthfully. you know, and I say that because I wish that we really did know why.
Yeah.
And we want to know why because we wish we could stop it. That's our human nature. But I have had Achilles tendon ruptures in 14-year-olds, 17-year-olds, 20-year-olds, many of them. And that's about as healthy as you get. And
Mhm.
these are people that don't have collagen disorders. They have nothing. These are just healthy, young people that are playing basketball or volleyball or some jumping sport, and it happens. Just like it happens in my age, your age. And I think the best that I have taken away from it, we can talk about Aquinas, we can talk about shoes, we can talk about surfaces, we can discuss all of that. But I can assure you, if there is one answer, the NBA would have solved it,
Sure.
because the NBA looks at this stuff so closely, and no matter how many parameters we try or variables we try to control, we still have it. And I think what I've come to appreciate is that our bodies, whether or not it's our bicep tendon or supraspinatus tendon, our quad tendon, our Achilles tendon, if you just get the perfect storm at the right moment, we can exploit the inherent weakness, and it tears.
Yeah.
And very few of them had underlying tendinopathy that I see. I mean, if somebody's 16 and they tear their Achilles, how much healthier can they be?
Right.
And I've got a good amount of those, under the age of 20. So
Yeah.
I would be I wouldn't be being honest if I thought that I could say, this is the risk factor, this is the cause. We have a lot of associated factors, but I'm not sure which one really plays the role. We know that it's usually this loading effect of eccentric, concentric, but you've got the angle at you got the ankle at the perfect angle, the knee at the perfect angle, the hip. It probably starts from the hip. If you ever watch some of these, it's a step back usually. So you get
Mhm.
this extension at the hip. Well, if I extend my hip by 30 degrees, in order to keep my heel on the ground, I need 30 degrees of dorsiflexion,
Yeah.
right? So maybe it starts at the hip with that first step, which then puts the demand on it eccentrically and concentrically. But that's as studied as shoes. So
Yeah,
um,
I think it's tough because it probably is multifactorial. During one of
sure.
the tracks at recent lecture, or sorry, at recent conference that we were at, someone was talking about dehydration levels, which I thought was interesting. And they were measuring dehydration levels, and I don't know how they were measuring that, but they inferred that the number of people who had an Achilles tendon rupture that also had dehydration, it was like 86% of the people that they tested with Achilles tendon rupture were technically dehydrated. I don't know if that's part of it, if it's the camel that broke the or the straw that broke the camel's
Yeah,
back, or
yeah,
if it's like, yeah, every athlete at the end
yeah.
of the game when they tear their Achilles is probably a little bit dehydrated because they were exerting themselves, and it's not because of the dehydration, it's a concurrent factor, but it's not the factor. So it's extremely complicated, but it does seem to be somewhat of an uptick recently. And I find
Sure.
it interesting because it obviously relates to what we do on a daily basis.
I think if I could narrow it to one thing, it may be the year-round training that's happening now.
Sure.
And I read a study recently that was interesting, and it was looking at intratendinous blood flow with Achilles load. And it was showing that as you went into dorsiflexion as well as concentric contraction, and I can't remember, it was for every Newton that you increased force, you were increasing the pressure internally by a certain amount of mercury, millimeters per mercury. So in essence, you were
Yeah.
creating a tourniquet effect, which
Hmm.
was happening. And so if you have somebody that's 220, they're really strong, this repetitive, maybe hypoxia that's going on could be playing it. But now, whether or not it's high school athletes, collegiate athletes, and we see it especially in the high school kids now, is that they're usually one sport focused from middle school at this point. And in America, at least, we have this thought that more is always better. And the worst thing that can happen to someone's kid is saying your kid has potential. And if you're told your kid has potential and you have some disposable income, probably the worst things that can happen for your kid, because it truly is, because
Yeah.
we've got high school, we've got club, we've got AAU, we've got select ball, we've got elite camps, we've got it all, right?
Yeah.
So and I think sometimes that year round, and I've seen so many great athletes be done by their senior year of high school,
Yeah.
and they never go on from that because their bodies are just tired. And I think maybe that's the one thing that contributes to it. Your other question you were asking about is the return to sport.
Hmm.
Um, I I think what happened with Kevin Durant was really a change in the tide, because there is no rushing this injury. To me,
Yeah.
this is an 18-month injury. And that's what I see when people fully rupture these. And I think there is a biological process of maturation that has to go on, and only time can do that. It's not more physical therapy, it's not more modalities. There's something about this tendon that needs that 18 months if you're going to really decrease the chance of re-rupturing it.
Yeah.
Um, and I've learned that somewhat the hard way, over the years. We're trying to be that doctor that has the magic, right? Or that can get them back sooner than anybody. And there are certain injuries we can do that, right? We can push the envelope. The Achilles is not one of them.
Yeah.
Not one of them.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5 email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plan. It's a really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol. Speaking of Achilles, let's jump into some of this a little more detail here, because I find the Achilles tendon fascinating. You want to take us through some of your thoughts behind Achilles tendon repairs? You seem to do quite a few of them. Obviously, sports medicine approach or sports medicine focused in your practice. Yeah, I'm sure you do more than your fair share of Achilles tendons. You want to go through this?
Sure. You'd have to scroll through these, but one
Yep.
thing that's changed dramatically for me is, I think there are a lot of considerations, and you and I were talking about this, right? The age of the injury. Do they show up 2 days after, or are they showing up 2 months afterwards?
Yeah.
Little bit of a difference there for us. The extent of the injury and the anticipated defect. This is how I approach this before we go into the operating room. Last thing you want to do is go into the operating room and have something you're planning on an end-to-end repair, and you just can't get there from here, right? If you
Yeah.
don't have plan B and C, or
Yeah.
sometimes D, you're in a difficult place. So you really want to try to anticipate the defect. The defect could be 0. Defect could be 9 centimeters. So you have to be able to be prepared for that. But looking at the age of the injury certainly helps us do that. The distal extent of the gastroc and the soleus. What I mean by that is that how far, first of all, your leg, Jeff, at your height and my height, they're different. And so the amount of aponeurosis I have is a lot less than what you have. So for
Mhm.
someone like you, I have a lot of aponeurosis to work with for turn downs V to Ys. Someone like me, I may only have 4 centimeters of that. You may have 15. So
Mhm.
how low does the calf come is going to determine where the aponeurosis starts and how much do I even have to work with. Because some
Makes
people have
sense.
a really low lying calf muscle, which really limits you. And I always work from proximal to distal. This is talking about repair and reconstructions. And when you get into those that have been delayed, whether or not it's 2 months, 6 months, the last thing that I have learned that I want to do is start my dissection at the place of the rupture. I always start proximally and work from normal to abnormal to get
Mhm.
tissue planes. And
Okay.
by doing that, that's going to help us keep a thicker tissue plane, because we all want to try to stay away from dehiscence and skin complications. And this is my general guidelines that I go through. And if the defect is less than 1.5 centimeters, this can also be with a insertional calcification or tendinopathy. If you want to excise that, and it's a centimeter and a half or so, you can usually get away with a gastroc recession. If they get into 1.5 to 3 centimeters, then the V to Y is my turn to. And again, these numbers are not hard fast because again, a V to Y in you is different than a V to Y in me. If that's because, we need a 2-to-1 ratio, not 1-to-1. So, but if it gets over 3, 4, 6, 7 centimeters, then a turn down is usually what I'll look for. If the defect is greater than 6 centimeters long, then an FHL transfer, and sometimes allografts are put in there because you may get in and you may have someone who has a leg short like mine, but has a defect that's 6 centimeters, and even with a turn down, you can't span it. And so now you're with an FHL, and then you may need an allograft. So hopefully you have that in the freezer. You can pull that out and try to find some way to do that. Or you can do a long FHL harvest or short harvest. So these are all decisions, but what I try to get across with this lecture is if you want to do Achilles tendon repairs as well as reconstructions, you got to have a really vast toolbox to go after. And let's say I've had this before. Patients have had an FHL transfer before, and they've re-ruptured their Achilles tendon. And I'm like, oh, what am I going to do now? Well, I've taken the peroneus longus and transferred it. So you just have to be able to come up with these things. And so I will always tend to do an FHL tendon transfer with any type of reconstructions. I think it's like a like a belt and suspenders type approach.
Sure.
This is a technique that I came up with, and we published it, I think, a month or two in Fast Track. And I will tell you, if there's one thing you can take away from this tonight, do this. When you get into Achilles reconstructions or you get into even primary repair, and we've all been there, even the end to ends, you tie it back together and the damn thing is sticking out posteriorly, and you're thinking to yourself, how do I get this skin closed? You've got the resonant pushing down on the tendon and the whole thing. Well, when we do these, one of the things that Mark Myerson described some years ago was releasing the deep coral fascia. So releasing that deep compartment fascia certainly gives your skin some flexibility to come around the tendon. One day I was in surgery and I was looking at it, I go, man, I just don't know if it's going to make it. Or, I'm concerned about the tension on the skin because as that Achilles becomes tight, it pushes posterior. It's going to cause compression on the skin, and sometimes they don't heal. So what this does, it allows you to be able to take, once you split the deep compartment, now you're looking right at the FHL or the FDL or whatever you want to look at back there. And now you've got these two nice pieces of deep compartment fascial tissue. So what I did was we took the fascia tissue and sewed it into the Achilles tendon. So you free it up first from the muscles, push the tendon forward, and then just take like an ovicral suture and run it the entire length, medially and laterally. And it pulls that Achilles tendon forward so it can't go posterior. And then it puts the Achilles in your repair directly in contact with the FHL muscle belly also. And the first time I did this, I did it out of probably desperation and innovation because I was concerned about getting the skin closed. But I've done this enough now that it really makes a difference. I have not had one dehiscence with it. I have not had contracture with it. I haven't had stiffness with it. So it has become a go-to procedure to me, sometimes even when I do more open primary repairs. And I think there may be some pictures in here of how it's done. And you can see it here. I think this was a turn down procedure, turn down. And you can see the pictures as we go through it. You can see that deep coral fascia, which has been released. The FHL has been done. The tendon's been reconstructed. And now we're taking that medial and lateral portion of that deep compartment and fascia band, and we're sewing it into the tendon. And I don't know if I included the pictures here, but this was one of the first or second ones I did. But when you pull the skin back over, it literally just lays on there. And now the fascia from the skin is easily approximated. The skin has zero tension on it, and it heals really, really well. So if there was one thing that I could contribute to anyone that's in the OR struggling with these, open up that deep compartment, do your repair, pull the tendon down, sew it into that, and it'll make your life so much easier.
Yeah, that's a great technique.
Because I'll tell you, I don't take care of diabetic patients, but I think the last thing you and I want is like an infected TAR or a dehiscence on an Achilles tendon.
Yeah.
I don't know if there's anything worse. I don't know. I don't know, right?
Yeah.
They're just because when you get that dehiscence of the Achilles, it goes downhill.
Yeah.
Right? Now you're dealing with, this large defect. Now you got to reconstruct it. You may have to get into tissue grafting, and there's probably nothing I dread more than that. And maybe that's how this came about, was out of either desperation or innovation or just divine intervention. But it really works.
We want to talk people through this short FHL transfer and what you specifically mean by that.
Sure. So the short FHL transfer comes right from the medial side of the ankle. So as you're doing your Achilles tendon repairs, again, as I alluded to earlier, we're going to open up that deep peroral fascia. And to me, there's two ways to get to this. It's very easy. Once you open up the fascia, you should be able to see the muscle belly, and you're just going to dissect the fascia off down to the fourth compartment. As long as you stay posterior and lateral to the tendon, you won't see the neurovascular structures as it sits anterior and medial to it. And then you come down into just the fourth compartment along the lateral side of the calcaneus, plantar flex the foot, plantar flex the great toe, which truthfully, you usually don't even need that much length. And then you just section it. And then when you section it, then we go ahead and we will whip stitch it and then place it into the calcaneus, usually with like a 6.5 or 7.0 interference screw with the foot into plantar flexion. And this was just showing gastroc releases for certain defects, So I was showing the two up top. When you see these are pretty ominous signs. That Achilles tendon distally is not going to be usable just
Yeah.
by looking at how much calcification is taking it up. So that's one where I look and I go, okay, I'm probably going to have a 1.5 centimeter defect. I look at how long their leg is. I know that probably just a gastroc release can span that defect, so I can cut that bad tendon out and advance it.
Hmm. I want to go back for a second. So the short FHL is what you're talking about, as opposed to open up in the plantar medial foot and doing a long harvest of the FHL. Do you ever run into any issues of not having enough length of your FHL with your tendon transfer here by harvesting it from the same posterior as opposed to going to the plantar medial foot?
Never have, never have. No, but again, let me be clear that the insertion is along the superior aspect of the calcaneus, so it's dorsal to plantar. So it's not as though I'm wrapping it around. Now there's others that I've had a situation where you debride the bad tendon of the Achilles that's there, and you have this 6 or 7 centimeter defect to it, and you may not have the length in the aponeurosis to do a V to Y or a turn down. And you may not have that allograft in the freezer because somebody forgot to order it.
Yeah.
So plan B or C or D or E right now is now we've got to, and now I still have a viable gastrocoelial complex. So I don't want to lose that. So then I would go into the plantar medial portion of the foot and do the long transfer, pull it back through, route it through the calcaneus and up through that band of tissue. And now I can anchor it in there. So now I've got the FHL muscle belly, as well as I still have some engagement of that triceps surae complex. But for this one here, doing it and inserting it in a dorsal calcaneus is never, length has never been an issue. In fact, sometimes you have a little bit too much, and because when you're passing it through the calcaneus, if it's too long and it hits the plantar cortex, then you can't tension it correctly. So sometimes being even a little, excuse me, a little shorter is a little bit better.
Sure. Let's jump ahead. We talked about the long FHL. All right, let's talk about primary Achilles tendon ruptures. What are your thought processes on open, minimally
Yeah.
invasive, jigs, no jigs? What are your thoughts on this?
Fortunately, I've practiced long enough where I've done all of them.
Mhm.
And if I showed you, I don't know if they're on here or not, some of my older slides when we had these long incisions, right? And we were doing end-to-end sutures to them. I look back at some of those now and I look at myself and I go, what the hell was I doing? And you would do this Achilles repair and then it takes you an hour to close it.
Yeah.
And the closure was harder than anything. You don't want the skin coming up at all. You're trying to get the aponeurosis back together. I've been practicing long enough that I've done these. And as I was saying, I still look at some of my old photos, or I see some today, and I just, I look and I go, gosh, that incision, look at that. And so I've evolved. I certainly have evolved. Probably about 4 or 5 years ago, I started using the PAR system. So I went through this evolution, right? Because I knew that every time I was doing these open repairs with these large incisions, you always know, no matter how good of a job you do, you're on borrowed time. And if you do enough of these, you're always going to have one that goes south on you. So I was always looking for a different approach. And when the PAR system came out, it was intriguing to me, but also somewhat, in my head going, I don't know, sort of like MIS surgery a few years ago. But I did it. And, it works really well when the tendon's really new, in that
Mhm.
first week or so, and you can really get it through there.
Yeah.
And I did about 15 of them with it, and I didn't have a problem. But my concern was placing those needles through there. I wasn't sure that I was getting tendon all the time. Muscle feels different than tendon, and then you had sutures all over the place. And I'm not bright enough to grab the pink with the blue and the yellow and loop this one. And I was just like, holy shit. Sorry. But the one part about the technique that I really liked was the using the anchor. So I started using the PAR system with the speed bridge,
Mhm.
and don't need to talk about that company or whichever, but was the knotless suture, anchoring into the posterior calcaneus.
Yeah.
Now, it made sense to me because up until that point, probably 10 plus years ago, Mark Glazebrook and his folks from Canada came out and were showing all the success with non-surgical treatment. So I had treated quite a few Achilles tendons non-surgical, and they did well. So I started to take that information and say, okay, maybe just getting this thing in the direct apposition with each other is enough. Because if it works on the non-surgical side, it should be able to work here.
Mhm.
So even though the pars were not giving me a problem, I just thought to myself, why don't I just make this incision longitudinal instead of horizontal? Maybe, you see it here, 2 centimeters or so. It's above those relaxed skin tension lines that go perpendicular to your incision. Just open it up. And now I just use the non-absorbable suture and put a modified crack out in that. And I have great confidence that it's in that proximal. And then I can pull it really well.
Mhm.
The distal incision, we pull up and dissect, and you see that distal sump of the Achilles tendon. And then by taking the suture passer and bringing it up into the incision and pulling those down and just getting that direct opposition and then putting the foot into plantar flexion. And one thing Bob Anderson taught me is, Mark, you can't over plantar flex them. Definitely plantar flex them as much as you can get because they'll always stretch out. And he's right.
Mhm.
He said, I remember one time he was telling me, I know there's going to be a problem when I see a patient and I read the op report from before and it says the tension was set in consideration of the contralateral limb. He goes, I already know it's stretched out. It's not tight enough. And I
Yeah.
took that to heart. So by taking those sutures now and then pushing them into the heel and plantar flexing it, I've been doing that for, gosh, I don't know, 4 years now. We're actually doing a retrospective study. I think we identified 152 of them that we're going to look at. And to the best of my knowledge, I can't recall an issue or a re-rupture with any of them.
Hmm.
It definitely, the healing is much better. There's no doubt about that. I can tell you, I know there's not been one skin issue with those, which it shouldn't because it's a little bit higher up. The relaxed skin tension lines, you're not fighting them. You've got some good subcutaneous tissue there, and the incision's only about 1.5 centimeters. So it's not that I'm in a rush to get the smallest incision possible because I want that primary suture having a really good grasp.
Yeah.
And then I know the anchors into the heel are really strong. So that's where I'm at now. So I've gone down to this, 2 centimeters, 3 centimeters. I don't really care how big it is. As long as it doesn't get into
Yeah.
that relaxed skin tension line coming across in that watershed area where there's no subcutaneous tissue.
Mhm.
So that's where I've evolved to. But I'm still pretty uh, conservative with them because around that week 4, 6, 8, they can get creep within the tendon if you start stressing them too much. And so this is definitely one that I don't send to physical therapy too early. I have the patients do their own range of motion. I work them through 6 sets of therabands over about 12 weeks, using the boot with the heel lift or the adjustable boot from Germany, which is fantastic. And usually by that 12-week point, we can start getting them into some sort of shoe. But I tell them from the very beginning, this is going to take you about 12 weeks to heal, and it's going to take you a year and a half to get better.
Hmm.
And when you lay that foundation from the very beginning, they have a good understanding of it. But
Yeah.
that's where I've evolved to now. So I've evolved out of the large incisions. I've evolved out of the end-to-end suture anastomosis. So it's really
Hmm.
a direct apposition. And I think what's the key is it's just like we saw in the non-surgical ones. And that's that peritoneum staying intact really goes a long way with these folks. Um, so that's where I've evolved to.
So, what are your thoughts on non-operative treatment? Because some of the later, more recent data does show pretty good outcomes for
Yeah.
non-operative treatment. But in my mind, not everyone is created equal. I treat a fair share of Achilles tendon ruptures non-operatively, but it's
Mhm.
generally a diabetic population, an older population, a sedentary population, where the risks do outweigh the potential benefits of fixing it. What are your thoughts on fixing versus non-fixing, with some of the newest research showing functional rehab, early aggressive functional rehab outcomes having a lower re-rupture rate than what we had originally thought when we compared operative to non-operative?
Yeah, I have a good deal of confidence in treating them non-operatively. One, the MRI, which you and I don't need to make the diagnosis, but I get the MRI to look at the gap. And if that gap is usually within, 2, 3 centimeters, I think that I can span that with the foot plantar flex and give them a good chance of recovery. If it's greater than that, I probably will recommend it. But to your point, in some of these high risk patients, and I'll tell you, you hit it accurately, Jeff. I was so excited when Glazebrook's works first came out and showed that we could treat these things non-operatively. Because like you, I had these patients, and you're like, I do not want to do Achilles repair on this patient
Mm-hmm.
because it's not going to work well for them. They're either not going to be compliant, skin issues, infection. They're just not a good patient. So when those papers came out, I was like, thank God, I now have something that I can hang my hat on and tell them, listen, the Canadians have told us
Yeah.
this works. It works great. And
Yeah.
I remember I was at some ortho meetings when those first came out. Let me tell you, Dr. Glazebrook, man, he created a firestorm. The debate that went back and forth and back and forth was really interesting. But
Mm-hmm.
ultimately, I think he has showed through that paper and subsequent ones that you can have some good outcomes. I like to sit with patients and I will give them the options, right? And I say, listen, you choose it. Let me answer every question you have. And I'll tell you the pros and cons. I'll tell you what I think you should do. I think there's a difference between right side and left side. If your non dominant side is injured and you're not in a running jumping sport, maybe this is better for you. But if it's your right side, dominant side, and you need to get back to work sooner, maybe this is better for you.
Hmm.
So I try to make that decision with the patient. I have had, interestingly enough, I had one lady I treated non-surgically, and every time that I would get her out of the casting, and my protocol usually was about 6 weeks in plantar flex casting, and
Mm-hmm.
then I would transfer them into a boot with a heel wedge and range of motion and such. I had a lady that re-ruptured it 3 times. Each time
Wow.
each time well, and it's interesting, each time I got her out of the cast into a boot, it was some accident. Like she's falling, getting out of the tub or or something of that nature.
Yeah.
And what did I do at that point? I stuck her back in a cast each time, and don't you know, she eventually healed the damn thing.
Hmm.
She really did and went on to having a full recovery. Because I was at that point, after rupturing it twice, now I'm going, okay, now we go into a reconstruction phase,
Mm-hmm.
right? And she just was not in a place of life and home care to be able to do it. So
Yeah.
I said, this is what we're going to do. And after the third time she tore it, I was getting a little impatient. I was going to cast her for 6 months,
Yeah.
but but I did.
Yeah.
And the body can do some amazing things. But to your point, Jeff, I think it's about knowing the patient, knowing the expectations, knowing the demand, having good conversations with them, and giving them pros and cons, and you and everyone as a team make a decision, just like with the athletes, right? Now, I think still when you have an athletic population, it doesn't matter if they're 40s or 50s. I think I'm still going to recommend primary repair in those folks. Yeah, especially right sided.
Yeah, I think that's reasonable. You know, you get a little pushback from some people sometimes that say like, well, you don't need to fix it. Everyone has their own opinion, right? Everyone thinks that they know best sometimes. And I think what the correct answer should be is it's individualized to the patient. You have that discussion. And I like to do that too. I like to lay out, like you said, all the pros and cons of operative versus non-operative, talk through the benefits and potential downsides with them. And let them we mutually come to an agreement. But if you had a high level athlete, like you said, if you had an NBA player that tore their Achilles, I assume that you would recommend operative intervention, be pretty aggressive with that, and then, functional rehab after that.
Yes, and that goes back into the other thing we want to consider in whether or not it's that Division One player or that Division Two or Three player or the professional athlete. You also have to consider what would the doctors who other than you that are really well known, what would they recommend? Right? So you also want to be in line with them
Mm-hmm.
because if it's that professional athlete, it's certainly going to be run by Bob. It's going to be run by, well, Marty's the man now. After Marty O'Malley, took care of Kevin Durant, everyone sends their Achilles to Marty O'Malley.
Yeah.
And that's really interesting too. I remember one time having a conversation with Bob, and what a great guy. And I'm so glad I saw your episode you had. You just see what a wonderful person he is. And I remember about 10 years ago, I was at an AOFAS meeting with him, and we were sitting around talking, and he said, "Look, Mark, I'm no better surgeon than you or anybody else." He goes, "I treat these injuries just like you would treat them, right?" He said, "The difference is that my group is willing to indemnify us against the outcomes." He said, and that's what you have to keep in mind. And so within the NBA, the NFL, you're seeing these players go to a select few physicians around the country now. And so now Marty is the man to go to for the Achilles tendon ruptures. Bob was Liz Franks for a while, so like whoever has some really great success with someone,
Yeah.
all right, we're going to send them all to Bob. We're going to send them all to Marty, and then I was at an AOFAS meeting 2 years ago, and they actually brought in a plaintiff's attorney, which was a really interesting discussion because at that point, I don't know if you recall, there was an orthopedic surgeon who had a verdict against him, but for $150 million, I think it was. And yeah, it's crazy. And so the team physician treated a posterior lateral meniscus injury conservatively, and was found to malpractice and $150 million against them.
That's
Now,
crazy.
It's crazy, but that's just one of these types of litigations that go on. And what that attorney was basically telling us is you can't indemnify yourself enough. So let me give you some education if you're going to do this of how to protect your assets.
Yeah.
And it's really something. And so when you have like a hospital for special surgery, okay, that is a big place now that will indemnify and take on the risk. Right. And they'll build all the internal structures to try to mitigate risks like Ortho Carolina would do. Or, so that's what we're seeing, especially in the pro athletes. And now we're going to start seeing in the younger athletes because of the NILs,
Yeah.
because of the indemnity. I mean, some of these NIL deals that some of these college kids have now are just off the charts. And so it's a whole different playing field now because of that liability that goes with it.
Yeah, that's an added issue for sure to dealing with these athletes. I think athletes tend to be a little bit higher maintenance than the average person. Like you said, they want to hurry, they want to get back, they want to push the boundaries of what's possible for the human body to heal, whether it's post-op or if it's conservative management. They're really pushing the boundaries, and they're high maintenance. Like you said, there's mom, there's dad, there's agent, there's coach, there's general manager, there's everyone involved in their care. And then you add in the medical legal component too, and it's all these extra headaches. So you really have to have a passion for sports medicine and treating these athletes, because there is a lot more than goes into it than just treating the average person off the street. Not that we're giving the athlete any magic pixie dust or magic medicine or giving them something better than the average person, but there's a lot more stuff that goes on behind the scenes with these athletes that can be a bit of a headache. And hats off to you for taking care of them, because having a good and reliable place for them to go to is fantastic.
Well, either that or I'm really dumb. One or the other, right? Here's a story for you. Whether or not you include this, not up to you.
Yeah.
So the Spurs drafted a player one year out of Oklahoma State, and he comes in practice. He suffers a Jones fracture, and this is right after they draft him. It's in summer workouts, and so of course we're going to fix it. So my senior partner David Schmidt's with me. And so this is the contrast that you're talking about. That particular day, I had 2 Jones fractures back to back. He was one, and then this other high school player from, rural South Texas. Okay. So we go in to fix this kid. And, in the operating room, I've got, the trainer, I've got, there's like 5 people all around. And then in the hallway, there's the assistant to the general manager, all here for this Jones fracture.
Wow.
And then my partner, he's sitting there with me. He's all right, let's go. And so he looks at me, he goes, hey, listen, no pressure. Only Big 12 player of the year, number 1 draft pick. They're not expecting a lot from him.
Yeah.
And so part of my language, he looks at me, he goes, don't fuck it up. I looked at him, I said, are you serious? I got a knife in my hand. I'm like, are you serious, Schmidt? Really? He's like, I've done this before. I put that 6.5 millimeter screw in David Robinson's foot. I'm like, all right, David. So we do it. And as you point out, done well, this is a 10-minute procedure. It's either a 5 to 10-minute procedure or it's a 30-minute procedure, right? It's either that wire is perfectly placed or now so I did that. And as soon as you do it, the x-ray from the fluoroscope is printed off, and then check, it's off. It's over to the general manager. It's off to his agent. It's off to his doctor. It's off to everybody.
Yeah.
And as soon as he wheels out, the OR then goes silent. The next kid comes in from Cuero, Texas. There's nobody with him.
Yeah.
I got paid the same for both of them.
Yeah.
So it was really it's such a contrast, right? That you look, and some days you do have to scratch your head and go,
Yeah.
God, did I really do what am I doing sometimes? But it's been good, and I'm sure you enjoy it as much as I do. I follow what you do really closely and see how great a work you do and what you enjoy doing. And I love how you post things and stir it just a little bit and get conversation going. And I'm the same way. I like good conversation. I'm not a big fan of when people say any, all, never, those types of things, or my way is this way, or this anecdotal stuff. Like, let's just nobody has a monopoly on education and knowledge, right? Let's just have a good discussion. And those are good to have. And I think you do a great job of doing that on the podcast. I think you do it in your posts. So I really applaud you for it and really appreciate it.
Thank you. Thank you so much. And I appreciate your time coming on the podcast tonight. I think this has been fantastic. I've loved getting to know you and connecting, and kind of one of those interesting things that social media, if you count LinkedIn as social media, which I guess we do, that has provided for us. So thank you so much for joining me tonight.
Thank you, Jeff, for having me. I really appreciate it. I look forward to seeing you in person again and realizing again just how tall you are or how short I actually am. But I am tall. I am taller than Ty Lue and Mike Tugela. All right, just for the record.
There you go. Awesome. Well, thank you so much. Thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Thank you, Jeff.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.